Welcome back to MLT 130. This lecture is going to cover the thyroid and the parathyroid. We'll first start out by covering information on the thyroid, and then at the end of the PowerPoint we'll get to the parathyroid. The thyroid produces two major hormones, T4 and T3, and it also produces calcitonin. Calcitonin controls calcium homeostasis. Think of this homeostasis as calcium's function in muscle contraction, structure, and in enzyme reactions. If blood calcium is too high, calcitonin is secreted to help lower the blood calcium. It will also be increased in medullary thyroid carcinoma. Thyroid carcinoma is basically thyroid cancer. The thyroid hormones help with metabolism, neurologic development, and amongst other things. The thyroid gland is found in the lower anterior part of the neck. It has two lobes on either side of the trachea, and it has a telltale butterfly shape. Iodine is an essential component of the thyroid hormone. If lacking the thyroid hormone in fetal development, it can lead to mental retardation, which is a condition called cretinism. Here's a trivia question. Which of the following in the blood would be elevated in a patient with medullary carcinoma of the thyroid? Would it be A, B, C, or D? Take a few minutes, pause the video, try to answer it on your own. The correct answer is C, calcitonin. Now let's talk about thyroid hormone synthesis. Iodine is a primary constituent found in seafood, dairy, and enriched breads. If intake of iodine drops below 50 milligrams per day, you may have a deficiency of thyroid hormone. Triiodothiamine, T3, and tetraiodothiamine, T4, are two active forms of the thyroid hormone. And TSH, our thyroid stimulating hormone from the anti-pituitary, stimulates the production of T4 by the thyroid gland. The thyroid gland contains follicles that are abundant with the protein thyroglobulin, which is comprised mainly of the amino acid tyrosine. Iodine then attaches to the tyrosine component of the thyroglobulin via the enzyme TPO, thyroperoxidase, to produce the hormone tetraiodothyronine, also known as thyroxine, or T4, as it contains 4 iodine molecules, hence why it's called T4. T4 is then catabolized into T3 because one of the iodine molecules is removed from T4 to form T3. So T3 is the metabolically active form of the thyroid hormone. Only a small percentage of T3 and T4 are unbound by protein and are available for hormonal activity. Proteins, thyroxine binding globulins, or TBGs, thyroxine binding prealbumins, TBPAs, and albumin are all proteins that bind with T3 and T4. So here's another trivia question. We just looked at this one. All of the following except blank are proteins that transport thyroid hormones. Pause the video, try to answer it on your own before you go on and get the correct answer. Is it A, B, C, or D? The correct answer is B, gamma globulins. They do not transport thyroid hormones. So let's talk about the thyroid hormone function. We have that hypothalamus pituitary thyroid axis that regulates thyroid hormone production, and that is your negative feedback loop. The thyrotropin releasing hormone, or TRH, from the hypothalamus stimulates the pituitary gland to make the TSH, which stimulates the thyroid hormone secretion from the thyroid gland. The negative feedback loop requires normal functioning hypothalamus, pituitary, and thyroid. Actions of the thyroid hormone include tissue growth, brain maturation, increased heat production, and oxygen consumption. Thyrotoxicosis is where you have too much thyroid hormone, and you can have symptoms of increased metabolism. Hypothyroidism is where you have too little thyroid hormone and you have symptoms of low metabolism. Okay, we have a think about it scenario, and it's based on that negative feedback loop. We have patient X with an underactive thyroid gland, and her blood, she has low amounts of T4 and T3 in circulation. And what would you expect her TSH and TRH levels to be? Would it be increased, decreased, or normal? Okay, you got to remember her T4 and T3 are decreased. So it's asking what's her TSH and TRH levels going to be. Think about that real quick before we go on and give you the correct answer. The correct answer would be you would see increased TRH and increased TSH because you're trying to raise those T4 and T3 levels. So you're trying, or your body's increasing that TRH and the TSH in order to try to increase the T3 and T4. So the answer to that question would be increased. How about if the patient has an excess amount of T4 and T3 in the blood? Okay, the opposite scenario, where we're going to see a decrease in the body's TRH and TSH because we already have too much. So it's going to turn off the production of that TRH and TSH because it already has too much. Basically, the patient already has an overactive thyroid. Here's just another trivia question. Tetraiodothione is another name for which thyroid hormone? Is it A, B, C, or D? Take a second and try to answer it on your own before you go on and get the correct answer. The correct answer is A, T4. Now let's talk about hypothyroidism, also called Hashimoto's. It usually affects women more than men. It can cause goiters in some patients, and goiters are just a term to describe a swollen thyroid gland. Hypothyroidism is an autoimmune condition. In Hashimoto patients, you usually have high levels of antibodies, the thyroperoxidase antibodies, TPO, and you also have thyroglobulin antibodies, and we can test for both of these antibodies. You can treat Hashimoto's or hypothyroidism with medication called levothyroxine. Some of the symptoms for hypothyroidism include bradycardia, hoarseness, weight gain, cold, dry skin, muscle weakness, and fatigue. In severe cases, it can cause myxedema, which is a coarse, waxy condition of the skin, and it's associated again with severe hypothyroidism. Now let's talk about hyperthyroidism. It's also known as Graves' disease, and it's also an autoimmune condition that typically causes hyperthyroidism. Patients have increased TSH receptor antibodies that may see increased TPO and thyroglobulin antibodies. You can treat hypothyroidism with medication, radioactive iodine, and surgeries. Nodular goiters are common and can also cause hypothyroidism. These are usually enlarged thyroid glands but are not due to white blood cell swelling. So these are not autoimmune in cause. Symptoms for hypothyroidism include heat intolerance, tachycardia, weight loss, weakness, anxiety, and tremors. In some cases, you may see bulging eyes. This is due to the autoimmune antibodies attacking the eye tissue and swelling behind the eyes, giving a protruding or bulging appearance to the eyes. Now let's talk about thyroid cancer. It's usually curable in situ, either in its natural or original position, but the removal of the tumor or the entire gland to prevent Metastasis is also an option. If the entire gland is removed, the physician will monitor the patient and order a thyroglobulin test, and it's used as a tumor marker. The thyroglobulin produced exclusively in the thyroid. Thus, if the thyroid gland has been removed, it should be undetectable. If it's detected, it indicates a cancer reoccurrence. So when testing the thyroids, there are certain things that we test for. Well, of course, we can test for TSH. It's the most useful test for thyroid function, and it is the screening test used to detect thyroid disease. And then we can also test our serum T3 and T4, and it's assayed in free form. So FT4 and FT3, meaning that it's not attached to a protein. We can also test for thyroid globulin. It's used to indicate the presence of thyroid tissue. If we've treated with surgery or radioactive iodine ablation, it should be undetected, and we usually use this test in patients with thyroid cancer to make sure the thyroid tissue has been removed. Ablation means we have had the removal or destruction of a body part or tissue. So what are the expected results of a thyroid disease states? Let's first talk about hypothyroidism or Hashimoto's disease. Patients will have an increased TSH and a decreased T4, T3. Okay, you can see patients with subclinical hypothyroidism with early stages and can see an increased TSH but normal to low FT4 and FT3. If not monitored or treated, will most likely develop into hypothyroidism. You will also see very increased TPO antibodies. Remember, you can test for these, and those will be increased. Also, remember that F on the T4 and T3 means free. It's not attached to a protein. In Hashimoto's, that TSH is increased because the body is trying to increase that T4 and T3. Now the expected results for hyperthyroidism or Graves' disease. Patients would have a decreased TSH, usually 0, and an increased free T4 and free T3. You would have an increased TSH receptor antibody and an increased thyroglobulin antibody, and you may have an increased TPO antibody. Remember, the TSH decreases because the body does not need any more T3 and T4 with hyperthyroidism. So here's just another trivia question. What is the screening test used by providers to detect thyroid disease usually? Is it A, B, C, or D? Make sure to pause the video, try to answer it on your own before you move on and get the correct answer. The correct answer is C, TSH. So let's look at some case studies together. This is case study number 1. We have a 40-year-old female that presents with a routine checkup. Her lab results are the TSH is 5.0, and you have normal ranges there, reference ranges. The free T4 is 0.9, and the free T3 is 2.9. What is her likely diagnosis? On the next slide, we're going to go over her likely diagnosis, but go ahead and look at those reference ranges and try to come up with a diagnosis on your own before we go on to the next slide. So looking at her results, the TSH is mildly increased, the free T4 is normal, the free T3 is normal. So her likely diagnosis is subclinical hypothyroidism. Okay, here's just another case study. We have a 39-year-old female that presents with the following symptoms: insomnia, weight loss, with an increased appetite, heart palpitations, and her labs are as follows. Her TSH is 0.01, her free T4 is 1.9, and then her free T3 is 7.5. And then her TPO antibodies are mildly elevated. And then her TSH receptor antibodies are markedly increased. So what is her likely diagnosis? Again, try to figure it out on your own. Look at those lab numbers, decide if they're increased, decreased, or normal. Try to come up with your diagnosis before we move on to the next slide and get the diagnosis together. So for our 39-year-old female, the TSH is decreased, the free T4 is increased, the free T3 is also increased. We already knew the TPO antibodies were elevated. And what is her likely diagnosis? Well, she probably has Graves' disease, and it is an autoimmune disease. Okay, let's do one more case study 3, before we go on to the parathyroid information at the end of this lecture. We have a 44-year-old female that sees her family physician with the following symptoms. She has weight gain, fatigue, cold intolerance, dry skin, constipation, and here are her lab results as follows. She has a TSH of 8.9, a free T4 of 0.4, a free T3 of 0.2, and her TPO antibodies are markedly elevated. So what is her likely diagnosis? Again, pause the video, see if you can come up with it on your own by deciding is her lab results increased, decreased, or normal, and then go on and get the correct answer or the correct diagnosis on the next slide. For our third case study, we know the TSH is increased, the free T4 is decreased, the free T3 is also decreased, the TPO antibodies are increased, so her likely diagnosis is Hashimoto's, and I hope everyone come up with Hashimoto's. The next topic that we're going to discuss in the last few slides are going to cover the parathyroid glands. There are 4 parathyroid glands that are located bilaterally on or near the thyroid gland. They secrete the parathyroid hormone. What is the function of the parathyroid hormone? We've already talked about the parathyroid aids in the regulation of calcium. Calcium and phosphate help make up the bone matrix. Magnesium is also a component that helps strengthen bones. Think back about our electrolyte unit. When blood calcium is too low, you have an increase in your parathyroid hormone. It's secreted by the parathyroid gland. Parathyroid hormone then increases the serum calcium level by increasing calcium reabsorption from the bones and increasing calcium reabsorption in the kidney tubules, and increasing intestinal reabsorption in the intestines by stimulating the production of vitamin D. Remember, vitamin D helps absorb calcium. Next, let's talk about vitamin D. Vitamin D is really a hormone. The parathyroid can stimulate vitamin D production to increase calcium reabsorption in the intestines. Vitamin D is synthesized by action of UV light to make D3. Different forms of vitamin D are produced in different areas of the body, such as the liver, the kidneys, and the skin. So now let's discuss parathyroid testing. The parathyroid hormone is tested in plasma by measuring different forms of the hormone. And some of the different forms of the hormone that we can test for include intact parathyroid hormone, N-terminal parathyroid hormone, mid-molecule, parathyroid hormone, and C-terminal parathyroid hormone. And the last slide we need to go over is the disease states for parathyroidism. You can have hyper and hypoparathyroidism. Let's first talk about hyperparathyroidism. It's a primary hyperthyroidism. It results in an increased blood calcium and may may be caused by a parathyroid adenoma or a tumor, a parathyroid carcinoma, or a hyperplasia. Hyperplasia meaning an enlargement of a tissue. You can see increase of calcium oxalate or kidney stones with hyperparathyroidism. And secondary hyperparathyroidism may be caused by vitamin D deficiency, and it presents with very low blood calcium levels or chronic renal failure. On the flip side, hypoparathyroidism results in decreased blood calcium. Increased phosphate may be caused by osteomalacia, autoimmune disease, inborn errors of metabolism, or unintentional removal of the parathyroid glands during thyroid surgery. This last slide is just some study questions that go along with this lecture and PowerPoint. You can answer these on your own as the study guide, but this concludes this lecture and video. If you have any questions or need further clarification, don't hesitate to reach out. I'm available through email or before or after class time.